Hi, and welcome to Chapter 7. We're going to look at cardiovascular system pathology today, and this is one of the more fascinating organ systems of the body, in my opinion, so hopefully you'll enjoy learning a little bit about some of the things that can go wrong with our cardiovascular system. So our chapter objectives for this week are to define and describe all bold-faced terms in the chapter, describe the physiology of the cardiovascular system, identify anatomic structures in both diagrams and radiographs of the cardiovascular system, differentiate the various pathologic conditions affecting the cardiovascular system and their radiographic manifestations, and provide a description of the special procedures that are used when imaging a particular pathologic. So we're going to look really closely here at the anatomy of our heart and a little bit about its function. So we know that our superior vena cava is going to drain the head and the upper extremities of its deoxygenated blood, the blood that's already been utilized and has already provided oxygen and nutrients to tissues. And that superior vena cava is going to dump into the superior portion of the right atrium. Into the inferior portion of the right atrium, we have the inferior vena cava that's going to be returning blood from the abdomen, pelvis, and lower extremities back to the heart. So these two components of blood will mix here in the right atrium, and then they're going to go through the tricuspid valve. And once they go through the tricuspid valve here, the blood will be in the right ventricle. When the right ventricle contracts, that will push the blood through the pulmonary valve, also known as a semilunar valve, and it will go out into the pulmonary artery. And this is the only artery in the body where you're having a deoxygenated arterial flow. From that pulmonary artery, it's going to branch into the right and left pulmonary arteries, where that blood is going to be delivered out into the circulatory system that really surrounds the lungs and basically is able to communicate with the alveoli of the lungs to drop off carbon dioxide and receive oxygen so that it can deliver that to the rest of the body. Now, once it comes back from the lungs, this will be oxygenated blood, and it's going to come back through the through the left and the right pulmonary veins, and they will dump into the left atrium at the posterior aspect of that atrium. From there, it will go through the bicuspid valve into the left ventricle. And through the left ventricle, it will go in through that aortic valve into the ascending aorta. That ascending aorta will give rise to what we call the ABCs. The aorta is A, the brachiocephalic artery is B, the left common carotid is C, and the S is the left subclavian. And after it gives rise to the A, B, C's, then it travels across the aortic arch and down into the descending thoracic aorta. And from there, the blood will go out to provide oxygen to all the tissues of the body. There are a few components that are important to think of in addition to just the route of the blood flow. And that really is the heartbeat that moves that blood flow through. So the heart is a pump, and the heart is going to contract and relax. And when the heart contracts, it's really going to utilize its muscle to squeeze the blood out. And so when the heart contracts, we call it systole, and during systole, these ventricles are going to contract and squeeze blood out through the pulmonary veins, the pulmonary arteries and the aorta. And then when that contraction of the heart relaxes, we call it diastole. And during diastole, the pressure in these ventricles is going to decrease, which allows blood to flow from the atria into the ventricles. Now, what makes the heart keep its rhythm? That is going to be an electrical type component that the heart utilizes. So we have AV and SI nodes that are here in the right atrium, and they provide electrical stimulation to cause the heart to contract. And so those nodes will deliver that electrical contraction to the heart through what we call the bundle of His that comes down into the into the ventricle, and then that ventricle will break that bundle of His down into what we call Purkinje fibers. And those fibers will kind of invaginate the muscle and stimulate that muscle to contract when they get the electrical stimulation. So that's another component of the heart. We really have the blood moving component, but we have the electrical component that allows the pumping contractions to occur as expected. The other thing to remember about the anatomy of the heart is it really has three different layers. The outer kind of membranous type layer is called the pericardium. The muscular layer in the center that does all of the contraction is called the myocardium. And then the inner cells are called the endocardium. Okay, so that's just a little review about the anatomy. If you're having any trouble remembering how it works, really watching YouTube videos, seeing those contractions in lifetime is really beneficial. All right, now the physiology or the purpose of the cardiovascular system, we know it's to maintain adequate blood to all tissues and body. And what adequate blood does is it provides the nutrients and oxygen that the tissues need to survive. Without adequate blood, our tissues will infarct or die and eventually necrose. And so a good cardiovascular system is obviously very essential to life. It accomplishes this task by utilizing those rhythmic contractions to push blood throughout the system. The heart rate is controlled by an autonomic nervous system, which is then able to help stimulate the electrical system of the heart. Now, even if the autonomic nervous system is not getting that done, often the sympathetic nervous system will take over and ensure that the nodes are still producing electrical signals. So that brings us to starting to look at some of the different heart diseases or pathologies that we might see. And you guys know that probably 60 to 70% of your job as radiographers is really imaging chest x-rays. And so these congenital heart diseases, much of the time, are something you can have an inkling of by looking at your chest x-rays. So the heart diseases we're going to discuss today are left to right shunts, Tetralogy of Fallot, and coarctation of the aorta. So since this is a congenital disease, we know it's something that a person is born with. It may be genetically tied, or it may just be something that went wrong in utero or in the development process that causes this. So looking at initially here the left to right shunts, we know that blood, as we talked about, really goes to the right atria, the right ventricle, pulmonary arteries, back into the left ventricle or left atria, and then into the left ventricle. Left to right shunts allow that increased pressure of the left side to push blood through defects into the right side of the heart. Now, one of the problems with this is that, well, first of all, we know that the blood that should be getting delivered out into the other areas of the heart aren't getting delivered. So it's going to decrease the perfusion of our interstitial tissues, which is going to be a negative thing. The other thing, however, is if this is my right heart over here, and this is my left over here, we know that blood should be continuing here to here to here to here, and then out on its way. Now, if we have shunting through something called a septal defect, typically, there would be a break either here or here. This would be an atrial septal defect. This would be a ventricular septal defect. And what would happen is when that left heart especially goes to contract and eject blood out the aorta, instead of going out the aorta, some of the blood will go back into the right heart. And then the right heart gets a little bit congested, and it has to send that same blood out to the pulmonary arteries again. And so they're going to get a little bit congested, and the process goes on and on. So they allow mixing of blood in the pulmonary circulations, and so some of the blood flow that goes out to the aorta actually is not oxygenated, and some is. And some blood that goes into the right atria, right ventricle, is actually oxygenated when it shouldn't be. So the process really affects the blood contents as well as backing up the heart, so it has to work harder and becomes more congested. Now, when a heart becomes more congested, there's more blood than it's able to work with, the muscle starts growing. The heart muscle, or the myocardium, just like any other muscle, the harder it works, the bigger it's going to get. And so by having to squeeze extra hard because it has a lot of extra pressure, because it's recirculating blood that doesn't need to be recirculated, all of those things are going to contribute to the heart becoming larger and larger, or hypertrophic. And that would lead to cardiomegaly. Now, this is something you can definitely appreciate on your x-rays. Now, it doesn't mean as soon as they start shunting left to right that you'll end up with cardiomegaly, but over time, as those muscles build up, that's typically what happens. So some of the types of those shunts that allow the blood to go left to right or right to left through those septums, the first type and the most common type is the atrial septal defect. And this is when our heart that should be in 4 different chambers has a break, and it allows blood to flow back and forth between this right atrial septal defect. Okay, so now one of the reasons you can sometimes see a atrial septal defect is because in fetal circulation there is a natural opening called the foramen ovale between the left and right atria. And that's purposeful in our bodies because fetuses are not oxygenating their blood in the lungs. And so it's not necessary for all of their blood to go out and get oxygen from the lungs and bring it back. So by shunting the blood from left to right through a foramen ovale, a fetus's circulation is really more effective for what they need. But upon birth, that foramen ovale should shut off, and we should then keep our right heart completely separate from our left heart. A second type of left to right shunt would be the ventricular septal defect. So like the atrial septal defect up here, we can really have a ventricular septal defect anywhere along the ventricular septum. Now, some of these can occur very high up, which comes with some other additional problems, and some of them will occur lower and lower in between the ventricles. Again, the problem with this is it's going to cause a backflow of blood. It's going to be circulating the same blood multiple times, which will result in congestion of not only the heart, but of the lungs as well. And the last thing that we talk about is the patent ductus arteriosus. And to understand what patent ductus arteriosus is, we really have to go back to fetal circulation again. And if I were to look at a fetal heart from the side, it would look something kind of like this. And that fetal heart would have an aorta, and that aorta would have an arch just like it does in our adults, and then a descending aorta. Now, in fetuses, they have this little connection from the pulmonary veins directly into the aorta, and that is called the ductus arteriosus. Now, the ductus arteriosus is there again because all the blood doesn't really need to go through the lungs. So as the blood comes out into the pulmonary arteries, there's this little shunt that can take them from pulmonary artery to aorta without having any blood flow to the lungs themselves. And so that shunt can help take some of the pressure off of the lungs. Okay. Now, if this fails to close after birth, then it's recognized as a patent ductus arteriosus, and it allows the introduction of non-oxygenated blood into the aortic system and will affect perfusion of oxygen. Here we see a chest radiograph of a patient with an atrial septal defect, and you can see here on the right side of the mediastinum that there is some increase in radio opacity over here, indicating hypertrophy of the atria. Now here's looking on ultrasound, and if you're looking at this, this demonstrates the left ventricle, the right ventricle, and a defect between the two. This is an atrial septal defect where you see a complete defect between the right and left atria with only a separation of the right and left ventricle. Over here we see something a little bit more subtle. We have the left ventricle here, the right ventricle here, which is quite small, and then you see that there's a defect in the ventricle right at the upper aspect where those where the mitral and tricuspid valves are. And sometimes they'll have a defect right at this top called this membranous ventricular septal defect, and sometimes the aorta will do something called overriding the defect. And when that happens, the aorta sits just above this defect, and then it takes in non-oxygenated and oxygenated blood and takes it out to the fetus. So both of these are fetal heart images of atrial and ventricular septal defects. Which brings us to Tetralogy of Fallot. And so when we hear tetra, we know that tetra means 4. So with Tetralogy of Fallot, it really is a heart syndrome that has 4 different common problems. So Tetralogy of Fallot is the most common cause of cyanotic congenital heart disease, meaning that babies born with Tetralogy of Fallot typically appear somewhat blue, because of their deoxygenated status. It consists of 4 abnormalities, and one of these is a high ventricular septal defect. So when we look at that last image that we just talked about, if I was looking at my ventricles only, and the lower part of my ventricular septum would be normal, my upper part here would be abnormal. So this would be a membranous ventricular septal defect. Now on top of that, it has a pulmonary stenosis. So we know that our pulmonary artery leaves our right ventricle. And in that pulmonary artery at some point, there's this narrowing. So you have a pulmonary stenosis with an upper ventricular septal defect. The next thing that you also have is an overriding aorta. So rather than having the aorta really leave the left ventricle and cross 90 degrees to the pulmonary arteries, you have an aorta that overrides both ventricles, like we just talked about. So there would be the aorta really almost going more parallel to the pulmonary artery than at 90 degrees to it. And because of all this other stuff going on, you end up having right ventricular hypertrophy. So if we add in the other components of our heart, here would be my left atria, here is my right atria, and then here are my pulmonary artery, here's my aorta. Because of all of this, you end up with right ventricular hypertrophy, and that tells us that my right ventricle is working really, really hard. So because blood is going out into the pulmonaries and the heart's having to squeeze extra hard because there's a pulmonary stenosis or a narrowing there, it's working extra hard to do that. Then it gets the blood into the pulmonary or into the lungs or into the circulation of the lungs, and then that blood is brought back into the left atria. Once it gets to the left atria, the blood goes down into the left ventricle, and then rather than all of that blood going out the aorta, half of it spills back into the right ventricle again, and so it becomes very congested. And because it's working so hard due to that pulmonary stenosis and the increase in blood because of the ventricular septum, it is going to get very, very large and hypertrophic. Now, here's something that you see that's similar in appearance. You can see that this is probably an infant chest, and you see that the position of their heart is similar to like an old wooden shoe. And you see that this left apex that usually it's right on top of the diaphragm is actually elevated. With patients that have Tetralogy of Fallot, the right ventricle gets so big, it enlarges, and because the right ventricle sits right about here, it's going to push that left ventricle off the diaphragm. So that's an example of Tetralogy of Fallot, and most of these infants will have a certain aspect of cyanosis or low oxygenation. That brings us to coarctation of the aorta. Now, this is kind of similar to what we just talked about with our stenosis of the pulmonary artery. So coarctation of the aorta, if this is my heart from the side view, and this is my aortic arch, coarctation of the aorta would demonstrate a significant narrowing at one point of the aorta. So let's say right here, it becomes very, very narrow. Now, when it becomes very, very narrow at that one coarced area, then that is going to make it very difficult to push blood through there. Because of that, it's going to increase the pressure on the left ventricle. So with coarctation of the aorta, we have the narrowing or constriction of the aorta. It's usually just beyond the branching of the blood vessels to the head and arm, which is actually fortunate. So we know we have the A, and then we talked about the B, C, S, ABCs, and those are going to go to our brain and our upper arms, or our arms. Most of these coarctations are distal to those branches. Okay. Now, because they're distal to those branches, usually those branches are going to have pretty good blood flow delivery to the arms and head. However, distal to that, you're going to have a lot less blood volume because of that coarctation. Now, this is the most frequent cause of hypertension or high blood pressure in children. The classic sign of this is normal blood pressure in the arms and very, very low blood pressure in the legs. So here's a beautiful example on MRI of coarctation of the aorta. Here you see the left ventricle. Here you see the aortic valve. Oh, excuse me, this would be our right ventricle, our pulmonary valve. Over here you see the aorta, which is coming out of the left ventricle from a different slice. And as it turns to descend into the thorax, you see this narrowing right here. Okay. All right, so I'll let you browse through these congenital defects that we talked about. Make any note of things that we didn't discuss. Okay, review question. What's the most common type of left to right shunt? That was going to be our atrial septal defect, and that's sometimes because we have a remaining patent foramen ovale. All of the following are anomalies associated with Tetralogy of Fallot except ventricular septal defect, that is an abnormality associated, patent ductus arteriosus, that is not, pulmonary stenosis, that is, right ventricular hypertrophy, that is. So B would be our answer here. Acquired vascular disease. So these are diseases that we aren't necessarily born with, but something happens at a point in our lives where we might demonstrate this type of disease. So we're going to talk about coronary artery disease, congestive heart failure, pulmonary edema, hypertension, hypertensive heart disease, aneurysms, traumatic rupture of the aorta, dissection of the aorta, atherosclerosis, thrombosis, and embolism. So coronary artery disease, we talked about the heart as a circulatory pump with 4 chambers, but what we didn't talk about is how does our heart get its own tissues nourished? So even though our heart is responsible for pumping blood flow to all the other parts of our body, it needs to have nourishment to its own tissues. It does that through coronary arteries. And the coronary arteries really are, they come off of the heart posteriorly near that aortic bulb. And when they come off there, they're rather low flow and they take blood throughout the heart and to feed the muscle. Now, when you have coronary artery disease, it's one of those arteries that's actually feeding the muscles of the heart that is becoming occluded or stenosed. Okay. The most common cause of this is atherosclerosis, which sclerosis means hardening. Athero would be of the vasculature, so it's hardening of the vasculature. And it's usually doing that by a deposition or deposit of fatty material on the inner arterial wall. Some of the things that can cause fatty material to deposit on your arterial wall are things like diabetes, because you have a lot higher levels of sugars in your system, and those sugars, if you think about what a crystalline sugar looks like, it can be really rough, and those extra sugars can roughen up the vessel walls, causing more things to stick with it. So that brings us to the next one, high levels of fatty material in your system. So having increased cholesterol, taking in lots of lipids, things like that can lead to plaque or atherosclerosis. Other things can be smoking, and a number of different genetic conditions that cause your lipids in your blood system to be high. Now, when you have stenosis or occlusion of these coronary arteries, we know that the muscles in our heart are very, very active. And when you're very, very active, you need a lot of oxygen and nourishment. And when we have atherosclerosis in the coronary arteries, that muscle can't get the oxygen and nourishment it needs. And that's when we have muscle infarction and necrosis. So some of the things we talked about that predispose you to coronary heart disease is hypertension, high blood pressure, obesity, that would increase our lipids and often is associated with diabetes, smoking, kind of like I talked about diabetes having those crystalline type sugars through our system, roughening up our vessels. Really, smoking introduces nicotine to our system that kind of has some similar effects. A high cholesterol diet, a lack of exercise, all of these things can contribute to coronary artery disease. And here's a really good example. So this would be a cardiac cath lab where they've introduced a radiographic catheter into the patient's coronary arteries. Usually they'll do this via access through the femoral artery. They'll follow that up to the heart and get into the coronary arteries here, and then they have injected contrast, and that they see that there is a near occlusion, a very, very significant stenosis right here in the coronary artery. Now, with that image we just saw last, with something like that, they might be, if there is a lumen left over, if it's stenosis, not a complete occlusion, they can often get in there and do angioplasty, where they could go in and they could re-expand that vessel. If it was completely occluded, then they might have to do something like a coronary artery bypass graft, which is known as CABG. Okay, that brings us to our next acquired disease, and that's congestive heart failure. Now, we talked a little bit already about some things that can cause congestion, things like coarctation of the aorta or pulmonary stenosis, anything that's not allowing that blood to be squeezed out of the heart and move forward on its merry way easily can cause congestion in the heart. And really, congestion is just a backing up of blood in the heart. Okay. So some of the things that can cause coronary heart failure are intrinsic cardiac abnormalities. So it could be something like that, coarctation of the aorta or pulmonary stenosis, something like that, something intrinsic to the heart system. Another reason is hypertension. All of that high blood pressure, there's so much pressure and so much resistance moving blood through the system, it will start to back up and pool in certain places, and one of those is the heart, and so it becomes congestion. And the heart, when it's congested, it continues to build up muscle, trying to get stronger, to squeeze harder to overcome that congestion. So with this congestive heart failure, you usually end up with cardiomegaly, because your heart's trying to beef up to do its job despite all this extra pressure. So that's how hypertension can lead to congestive heart failure. Anything else, any other obstructive processes that prevent blood from normally flowing out the heart can cause congestive heart failure. here's a patient with congestive heart failure. And what you see happening is that their heart here is becoming enlarged and taking up the majority of their chest. They're also having a lot of patchiness appearance in their lungs. And why you would see that patchiness in their lungs would be that even though the heart is growing, trying to squeeze that blood out really efficiently, it's having trouble doing that. And so what's happening is something that started out as, let's say, an aortic problem. It kind of has a backstepping process. So say my initial problem started in the aorta, and I had a near occlusion there, and it caused an increase in pressure down the aorta into the left ventricle. Well, all of a sudden, the left ventricle is having trouble draining itself, and so when the left atria needs to fill the left ventricle, it can't drain into the left ventricle. So then the left atria is fed by the pulmonary veins that come from the lungs. And when those pulmonary veins that come from the lungs aren't able to dump right into the left atria, then it backs up fluid into the lungs. So it's just this backstepping process where you start with a little issue, it has a problem, but then everything leading up to that issue also becomes affected. Now, when you have that backup or congestion in the lungs, we can call that pulmonary edema or swelling in the lungs. And it's due to an abnormal accumulation of fluid in the extravascular pulmonary tissues because typically of congestive heart failure. And that congestive heart failure goes on to cause pulmonary venous pressure increases. And that's usually due to the left-sided heart failure and can also be caused by pulmonary venous obstruction. Other causes that are a little bit less common that can lead to pulmonary edema rather than congestive heart failure would be uremia, where you're not getting rid of your urine as well. Narcotic overdose, exposure to noxious fumes, excessive oxygen, high altitudes, fat embolism, adult respiratory distress syndrome, and other neurologic abnormalities that could affect the neurologic function of the heart and lungs. So here's an example of significant pulmonary edema. This heart is very large, you can see, and then you see this increase in radiopacity in the hilum. That's going to indicate that there's some fluid being maintained in the pulmonary tissue, causing pulmonary congestion and pulmonary edema. That brings us to hypertension. So most of us aren't born with hypertension. Usually it's acquired over time. It can have a genetic component where it runs in families, but this is also known as high blood pressure. And most of the time, anything with systolic pressure over 140 or diastolic pressure over 90 would be considered high blood pressure. Hypertension is the leading cause of strokes and congenital heart failure. The blood pressure is a function of cardiac output, or how much blood is leaving the heart, and the total peripheral resistance of the body. And really what provides peripheral resistance are those distal small little arterioles. So if we look at how the blood system operates, basically we have our heart. Our heart has an exit, and that's called our aorta. And our aorta comes out, and our aorta is going to divide into multiple different branches. So we'll use this common iliac artery, for example. So blood comes out, goes down to the aorta, goes out into lots of different branches, but some of the blood makes it to the common iliac artery here, and we have a left and a right of those. Now, then it goes through the iliac artery, and it will go through smaller arteries and smaller arteries and smaller arteries until you get out into the distal tissues of the little bitty toes. And then you have these little teeny tiny arterioles that end in capillaries. And it's at that capillary level that it only lets one blood cell through at a time. allowing for the oxygenation of interstitial cells and the taking in of waste of the blood cells. At that point, it moves on from the capillary into the venule. The venule dumps into a vein, and so on and so forth. You're part of the venous system. Now, what really causes hypertension most commonly is an increase in the total peripheral resistance. So as we get farther and farther out here from the large artery, and our arteries get smaller and smaller until they become arterioles, we actually have nerves in our system that interact with those arterioles, causing them to expand and contract. And sometimes there's a reason that certain arterioles will contract. Say if I'm really, really, really cold and my body knows that I need to keep heats on my most essential organs for the longest amount of time possible, I would have a lot of arterial constriction in my extremities because those are not essential to life. Okay, it would cut or reduce the amount of blood flow going to my extremities because it wants to maintain all of that blood in my trunk because that's in brain because that's where my essential organs are. So with hypertension, what often happens is you're going to have an overall miscalculation of these arterioles, and they're going to over-restrict. And when they over-restrict, they provide resistance against the blood trying to get to them. So how does that hypertension or the high blood pressure because of arterial resistance cause heart disease? So if it happens for a long-standing time, it can cause narrowing of those blood vessels and an increased resistance to flow. When that happens, the ventricles are going to have to work harder to push blood out into the arterial system. So as that happens, our muscle cells typically of the heart are then going to hypertrophy and lead to cardiomegaly. And here's an example of a congestive heart disease patient with a radiograph. And you see this very enlarged heart in a lateral view chest x-ray. That brings us to aneurysms. And aneurysms are a local dilatation of an artery. And one of the most common places we see this is called a AAA, an abdominal aortic aneurysm. So that large aorta in your abdomen is the most common place for these aneurysms to occur. There can be two different types. The first type we talk about is a saccular, where if you have your aorta or your vessel coming along and there's some sort of little defect on one side and it creates a little sac, that would be a saccular aneurysm. If you have an aneurysm that is equal dilatation, relatively equal on both sides like this would be called a fusiform aneurysm. Here we see a number of different aneurysms. One right here in transverse on an ultrasound, you're seeing that this is a very large aneurysm, or it's a very large vessel. So if I were to go up and look above this vessel, the vessel would be much smaller. If I were to scan down and look below this particular area on the vessel, it would look smaller. But at this point, it appears very wide. And that would indicate that this is a fusiform abdominal aortic aneurysm. Now, this brightness that you see around the edges here, that's probably some development of blood clot at the aneurysm itself. Here you see a CT. This whole thing is aorta. This is a very large aorta. It's bigger than the spinal body. So this is obviously an aneurysm. And the reason you're seeing two different radio opacities on here is that this darker area is filled with blood clot. This lighter, brighter area is filled with blood. So not only do we have an aneurysm here, but we have a significant blood clot going through the aorta, which is taking blood to our extremities and very likely to knock off a piece of that clot that would then go have significant harm on the patient. Here's the same patient. Here it is in a coronal type plane. And here you see the aorta. And here you see that fusiform aneurysm with some blood clot on both sides. Another type of acquired vascular disease is traumatic aortic rupture. So this is exactly what it sounds like. It would be typically from trauma, and it would be a rupture of an aorta. And we know that that aorta contains so much blood that this would really be a devastating event. It's usually fatal, and it's a complication of closed chest trauma. And it will often be things like rapid deceleration in a car, in that seatbelt crushes your chest, or a blast with significant impact, maybe in a war, or working with a blow-up crew or something, and then compression of that chest. Any of those can cause an aortic rupture. Usually the aorta tears occur distal to the left subclavian artery, so it would be in your aorta after your A, B, C, S. So here's an example of a traumatic aortic rupture, and you see that there is fluid collecting around the heart in the upper pericardial area here. The patient has an ET tube in, trying to breathe for them, but this would have to be surgically repaired immediately for the patient to survive, if that's at all possible. Our next abnormality we'll talk about is aortic dissection. Now, just like our heart had 3 layers, basically a pericardium, a myocardium, and an endocardium. Your vessels have basically the same thing, a 3-layer vessel wall. Now, our blood usually flows nice and smooth between our layers of what we call adventitia. So where we have in the heart, we have pericardium, myocardium, endocardium. In the vessels, we have tunica media, tunica intima, which is muscle, and tunica adventitia. And when we have an aortic dissection, what happens is blood that was supposed to always go down the center of the canal somehow gets in and starts to peel off one of the layers of the vessel wall, or dissect it. Now, as this happens, blood is going to go into this false canal, and it is going to continue pushing down, trying to open up this false canal farther and farther. However, blood in that canal is never going to get into anywhere useful. So it's basically going to be shutting off, taking away blood out of the circulation that's going somewhere useful and putting it into a circulation where it's not going anywhere. The other problem here, as the pressure increases in what we call this false lumen, it's going to tear that tunica intima more and more significantly until really the vessel can be totally filled with dissected aorta, and there's no normal blood moving through anymore. With this, it creates a very life-threatening situation. It's most common in patients with arterial hypertension. However, it can also be found in things like trauma, congenital defects, or Marfan syndrome, which is a connective tissue disease. So here's an example of a dissection. So here's the heart, here's the aorta, and you see a huge, just huge, excuse me, I'm looking up here and I should be looking back here. This is the dissection of the ventricle. This is the dissection of the aorta back here. And then obviously there's some bleeding out into the space. So this is a hematoma, or blood collection external to the aorta itself. That brings us to atherosclerosis. So again, sclerosis was our hardening term. Athero then would be vessel, and it's caused by thickening, hardening, and loss of elasticity in the arterial wall. And usually that's due to deposition of plaques on the wall itself. It will produce a cumulative, progressive narrowing of the vessel that can lead to occlusion eventually. It's just one form of arteriosclerosis. Its major cause of vascular disease in the extremities and is atherosclerosis. So here's an example of atherosclerosis in the popliteal artery. So here you have a patient that has had a arteriogram where they've accessed the artery, injected contrast, and they're watching for it, the contrast to fill all the vessels. And as you see this popliteal artery come up through here, you see all of a sudden it ends at a blunt end. You see something very, very similar on the other knee. It ends in a blunt end. If your patient's been having a lot of pain and discomfort in this, post or in this area just above the knee, this could really be due to atherosclerosis. Okay, that brings us to thrombus and embolism. So anything that wedges itself in a vessel, so if this is a vessel and it's getting smaller and smaller and smaller as it goes out into the periphery, anytime there's something able to lodge itself in that vessel and cut off blood supply, we call that an embolism. Now, if that embolism happens to be made out of a blood clot, we call that a thrombus. Now, one of the common embolisms is from a thrombus. So how do we know, or how do we avoid letting our patients get a thrombus? And the answer is actually pretty easy. Things that lead to a thrombus are stasis, or blood that becomes stagnant, is holding still, endothelium and injury of inflammation, and then blood changes. So any of those can cause an increased probability of thrombus in the system. Embolism, on the other hand, is part or all of the thrombus that becomes detached from the vessel and enters the bloodstream and then gets lodged in that bloodstream so that no other blood perfusion can occur past that point. Now, we talked about a thrombus being a blood clot embolism, basically, but there are other types of emboli, and those are fat, which is just, free-floating fat or lipids collecting in a vessel, occluding it. Or they could be from septic, where you have so much bacteria in your system. It's actually those bacteria molecules that are grouping up and causing an occlusion. It can also be air introduced into the vasculature. So here is an example of an acute embolic occlusion. And so here we have our aorta, and here would be our right renal artery. Over here is our left renal artery. And you see that right renal artery moving blood easily from the aorta all the way to these segmental arteries of the kidney. Over here, you see that left renal artery take off, and then it basically stops dead in its tracks. Without blood flow, your left kidney will infarct and die. All right, that brings us to a quick review on some of the congenital abnormalities of the cardiovascular system. That brings us to our valvular disease. So these diseases really are going to have to do with the valves in the heart typically. So our valvular diseases can start with rheumatic heart disease, mitral stenosis, mitral insufficiency, aortic stenosis, aortic insufficiency, and infective endocarditis. So rheumatic heart disease is, rheumatic fever is an autoimmune disease that comes from a patient having a reaction to antigens from a previous strep infection. It damages the heart valves. Usually it affects the mitral and aortic valves, or those semilunar valves. Damaged valves are either stenotic and they're too hardened to move appropriately, coming together and opening up, or they're inefficient and insufficient and they do not close completely. So most of the time the problem with these is that they're going to be leaky valves. Mitral stenosis is when it usually comes due to rheumatic heart disease, and it happens when between that between that left ventricle and the left atria. It's kind of like an ice cream cone. But between those two, we have our mitral valve. And when that mitral valve either stops opening correctly or stops closing, that's when we get mitral stenosis. When we have mitral stenosis, it prevents blood from easily moving from the left atria into the left ventricle. And because of that, my left ventricle underfills. And so when it squeezes to put blood into my aorta, it's not going to get a lot of blood out. And that blood is necessary to go perfuse my tissues. So this would be a problem. Secondly, is if there is a lot of stenosis and the left atrium is not able to push that blood flow to the left ventricle, then it's going to become, the left atria would become very congested, which would in turn congest the pulmonaries, which would in turn congest the left ventricle. So it's always a step-by-step process. Okay, so here you see a patient that has a very significantly sized heart. This patient has cardiomegaly due to mitral valve stenosis. And here you can see it anterior to posterior. Again, it's quite enlarged. Mitral insufficiency is most often caused by rheumatic heart disease. And this can also be caused by a rupture of chordae tendineae. And this is something we hadn't talked a lot about. So if this is my atria up here, and then here's our ventricles down here. The chordae tendineae are these little cords that kind of attach themselves. If this is my vessel, the chordae tendineae actually attach themselves to the valve. And so by having this attachment, when that ventricle contracts and pushes back a lot of pressure on these leaves of the valves, these chordae tendineae are going to help kind of hold them down. So that is one of the major causes of mitral valve insufficiency, is the lack of use of chordae tendineae, and which would cause the valves to open back up in the wrong direction. Now, with mitral insufficiency, regurgitation of blood into the left atrium, whenever we have ventricular systole, is going to cause overfilling and dilatation of that particular chamber, which will ultimately lead to the decrease of ventricular stroke volume. So here's a patient, excessively large heart. They obviously have cardiomegaly, very rounded at the right ventricle and atrium. So aortic stenosis, again, this can be caused by rheumatic heart disease or rheumatic fever. It's or it could be a congenital valvular anomaly or abnormality. Now, the aorta is a three-valve passageway, and they call it a tricuspid valve because you have the 1, the 2, and the 3 valves, which that's not very pretty. They really overlap and make a beautiful little pattern. But we have these 3 valves, and aortic stenosis of these 3 valves would mean that they're not opening adequately to allow blood into the aorta. The obstruction then causes the left ventricle to work excessively hard, which then causes it to congest and hypertrophy. So here's an example. Here is our our aortic stenosis right in this general area. And because it's causing so much backup into the left ventricle, you're seeing the left ventricle begin to get enlarged. Now, aortic insufficiency really means that that the aorta is more just leaking. Again, this can be caused by rheumatic fever, but syphilis, infective endocarditis, dissecting aneurysms, and Marfan syndrome can also contribute to this. Reflux of blood from the aorta during diastole causes volume overloading in the left ventricle and dilatation of the chamber. So here's an example. So here we have aortic insufficiency. So as blood goes to get pushed out into that aorta is not allowing the blood to go all the way through and move on down down and out the aorta. So it backs up into the left ventricle, and you get left ventricle enlargement, and then that causes it to back up into the lungs, and then that back up into the lungs can cause right ventricular enlargement, and so on and so forth. That brings us to infective endocarditis. So endocardium is going to be the inner lining of the heart. So endocarditis refers to inflammation of the inner lining of the heart, and it refers to the development of nodules or vegetations on the heart caused by deposits of bacteria or fungi. And when we say nodules or vegetations, you're almost thinking about little bacteria or fungal growths right on the valves. Vegetations of infective endocarditis, this would be those infected antigen cells, are going to fill with bacteria and sit there on the aortic valves. These are best seen with echocardiography. Okay, so you can look through some of those acquired diseases of the heart. And that brings us to pericardial effusion. So pericardial effusion means that there is an effusion or fluid collection around the heart. So within the pericardium, we're going to take on fluid around the heart. It's the accumulation with that fluid. It usually results from bacteria, viruses, neoplastic involvement, and idiopathic pericardial effusion. Rapid accumulation of fluid around the heart can interfere with the cardiac function because it's going to apply pressure to the pump. So by applying pressure to the pump, it makes that heart not pump as effectively and can cause some significant heart problems with that fast onset of accumulation. So here's an example of a pericardial effusion. You see that this is actually the heart here, but this is fluid trapped all the way around the actual heart. One of the things with pericardial effusion that complicates it, if there's so much effusion there, it's not allowing the heart to expand and contract effectively. The patient may have a very difficult time breathing and feel very low on oxygen, and that can be called tamponade. And that just means that the heart's being compressed by pericardial effusion. One other quick note on pericardial effusion, and I've been seeing this frequently as we scan each other in our ultrasound lab, a number of our students have had that idiosyncratic or unidentified pericardial effusion. That brings us to venous disease. So a couple of the important venous diseases are really deep venous thrombosis and varicose veins. Now, when we talk about deep veins versus superficial veins, in our legs, our deep veins are going to drain the heart of our muscles. Okay, so they're going to really drain those big muscles or big producers of deoxygenated blood, take it into the venous system, deliver it through the venous system up into the basically the IVC, who would then deliver it to the heart. Now, in these deep veins, if a clot gets lodged or a thrombus gets lodged and hangs out there and then it gets dislodged, it can transition right to the heart where it would get wedged. It could get wedged in a coronary artery or pulmonary artery or who knows where. So that's why we really worry about these deep vein thromboses. Now, do realize that along with a deep venous system, our legs, lower extremities, and upper extremities often have a superficial venous system as well. Now, when we're talking about the lower extremities especially, we don't really worry about clots in the superficial venous system because usually they're so tiny that they don't cause many problems anyway. Our other discussion is going to be varicose veins. So let's get going here. So a deep vein thrombosis, or a DVT, usually involves the lower extremities. It's more common after things like travel, surgery, anything that's going to increase stasis or slowing down of the blood in your venous system could lead to DVT. It can be a source of potentially fatal pulmonary embolism. So if that clot breaks away, like I mentioned on the last slide, wedges into the pulmonary artery, then that could actually kill the patient. Precipitating factors that can make DVTs worse would be trauma, bacterial infection, prolonged bed rest because that static lack of movement, and then the utilization of oral contraceptives. A DVT can be the earliest symptom of a malignancy of the pancreas or GI system because those increase the body's tendency to clot. So a DVT, here's an example of a DVT on a venogram. So a venogram is an injection of contrast into the veins and then evaluation under fluoroscopy. And when they did this on this patient, you can see that this is a knee right here. So this is the popliteal vein right in this general area. And you see that you have nice contrast filling all the way up here, but in here you start to see this big filling defect. And that's because that area of the lumen of the vein is actually being blocked by thrombus, so it won't allow contrast to fill there. That brings us to varicose veins. Now, varicose veins are just dilated veins. They can become very tortuous, and they're more commonly seen in the superficial veins rather than the deep veins. One of the things that can cause varicose veins we mentioned that there's a tunica adventitia, tunica media, and tunica intima layer in every single one of our vessels. Now, when we have vessels that have disruption and weakening of those layers, then they start to dilate. The other thing that can happen is that innermost layer, the tunica adventitia, is going to have valves. And they're just going to be folds of adventitia that come together so that when blood gets pushed past a valve and tries to go backwards, those valves don't let them do that. Now, sometimes people will have valve incompetency, and these valves will stop working. So blood is moving forward, and then it swooshes right back, and then it moves forward, and it swooshes right back. And because of that, it is going to increase congestion in those veins. And as those veins have an increase in congestion, they're going to increase in diameter. And what used to be a nice skinny little vein is going to become large and very tortuous. Here's an example of those varicose veins. Okay, so you can take a quick look at the venous system here. And a couple review questions. Which valves are most often damaged by rheumatic heart fever? And that is going to be your aortic and tricuspid. Or excuse me, aortic and tricuspid. All right. Which term refers to the inability of the heart to propel blood at a rate and volume sufficient to provide adequate supply to the tissues? This would be your congenital heart failure.